Okay, here we go. Which assessment finding indicates a worsening of preeclampsia and the need to notify the healthcare provider? Good job. The nurse would anticipate this with abruptio placentae, which is another word for placental abruption. Yeah, probably delivering the baby. If it's a very small abruption, they might be able to monitor, but most often if there's a placental abruption, we are delivering.
Yeah.
The client understands their insulin needs in the second half of pregnancy if they state they may require what? Right? Because they're becoming more and more insulin resistant.
The
They're needing
2
more.
to 4 fold, correct?
Yeah, perfect.
Okay.
It says you're on fire. Like
We'll
that
see.
video.
I usually mess up the select all that applies.
And well, there's no select all that applies in this game. So that's good.
I like that.
It's hard to set up at the Kahoot with select all that apply. When gathering items for a client on magnesium, which highest priority item should the nurse obtain? Yep. What are we going to use calcium gluconate for?
It's the antidote for toxicity.
Perfect. Which statement should alert the nurse to the worsening of gestational hypertension? Yeah, because that's going to be those cerebral involvement that we're worried about for preeclampsia. So my swelling went down, my headache was resolved with Tylenol, and I had heartburn when I ate spicy food. Those are all things that are normal. The nurse's priority will be to assess for which complication for a 35-week gestation in a motor vehicle crash.
I don't know if your Wi-Fi is being funny today, but it could be mine, but you're kind of garbled every once in a while.
Oh, shoot. I had that trouble in class too. I ended up having to use my hotspot. I could switch.
And it's not too bad. I mean, I think it's just the audio. I'm not having an issue with the visual.
That's weird. Let me see which one I'm using. Well, that's the one that should be better. Well, let me know if it gets worse. I definitely don't want to problem with it during the exam prep review. No one said anything about it during class this morning. It's so weird because I'm on cable and I pay a lot to have like a ton of bandwidth. So it's annoying when it's not doing.
Me too.
Technology.
I know. I pay a lot of money for my Wi-Fi, and then my microwave blocks the signal to my room.
Oh. What prescription should the nurse question for a 37-week patient with premature rupture of membranes? Yeah, so what are we worried about?
Infection.
Infection. And even
you don't want to introduce anything.
Right, perfect. Even though we use a sterile glove, every time we're going in, we can bring bacteria with us. Bad idea. Assessing the fundus of the uterus, the nurse notes it feels soft and boggy. Which nursing intervention is appropriate? Yep, massage the fundus. We want to encourage that muscle to contract. Now I'm on fire. In a premature preterm rupture of membrane patient, maternal fever, as well as maternal and fetal tachycardia are clinical findings of what? Chorioamnionitis. Yep, and that's that infection.
Mhm.
The exact one we were trying to prevent by not checking her too much. The
Yep.
nurse knows to frequently assess the following to identify magnesium toxicity. Good. What else should be in that list? I started to change the list and then I realized that because this game matches the slides from the exam 2 prep and it matches the NCLEX book, so I didn't change it. But what else might we see?
The clonus is affected as well, right?
Well, if the clonus goes away, that's a good thing.
Okay.
Yeah, it could be affected, but that wouldn't be a sign of toxicity. If we had clonus, now we don't have clonus, that's good.
Urine output is affected?
Yeah, urine output is going to be the other thing that we're really watching for magnesium toxicity. Yep.
Because if they're not expelling the urine, they're retaining the magnesium.
Exactly. And so what do we want the urine output to be?
30 mils an hour or more.
Perfect. The provider prepares to perform an amniotomy at -2 station. What will the nurse anticipate as a possible outcome?
Yeah, that one I'm not 100% on, but I'm just going to guess. Nope.
Okay,
Yeah,
so
the monitor.
what's the amniotomy?
That's breaking the membrane. Yep.
Okay.
No, ADD got me on that one.
That's okay. -2 station means the baby's still high in the pelvis. And so if the head,
there's still room for the cord to come down.
Yep, the head's not well applied, the cord can come down.
Gotcha.
And so truly, like if I assess a patient, if I check her cervix and I put my fingers through her cervix and I touch the fetal head and it floats away, I tell the provider we can't break her water right now. But actually what I say is you can assess, but the baby was ballotable for me. And that is my nurse way of saying, don't do it.
That's the allotment where you can move the baby and it floats.
Yeah. So ballotment early in pregnancy has to do with, it's a little bit different when we talked about it in, I think, week 2, where you can't, like if you touch through the lower uterine segment, you can like touch the presenting part and it floats. In labor, I can go through the cervix and actually touch either the membrane or I can run my fingers through the baby's hair. And so if the water's broken, if they're not well applied in the pelvis, if they're not nice and low, then, and the water bag is still intact, I touch the head, it can float away. And we call that ballotable. We call that ballotable. And so it doesn't, how far can it float? Because it's, it doesn't have a lot of space, but it moves up and then it comes back down. It can kind of bounce on your finger. It's kind of weird.
Yeah.
Don't want to break the water. So you would
want to see, like, at what station, like at a 0 station is where you'd want to rupture the membranes artificially? That way they're actually like engaged and in position.
Mhm. If they do it at -2, it just needs to not be blottable. But -2 is a good indication that the baby's not well applied in the pelvis yet. So then we have the possibility that as the fluid
Okay.
rushes out, it could bring the cord down with it. And then we're going to monitor the heart rate.
Okay.
And we're monitoring the baby, and what might we see with the heart rate if we prolapse the cord?
So a prolapse is going to be late decelerations.
Hmm.
No. Cord compression, variable deceleration.
Mm-hmm. Yep.
Right?
And so you're
Yep.
going to see variable decelerations unless the pressure stays constantly on the cord, and then you're actually going to get a bradycardia.
Okay.
Yeah. But so yes, cord compression is variable decelerations. You are correct. But it's just if the
I try and remember the veal chop
the veal
every
chop is your friend.
time.
The veal chop.
I like that one.
Yep. Good. I didn't mean to pass you up. You gotta. Which assessment
the
finding should cause the nurse to immediately discontinue the oxytocin infusion?
Had to think about that one. So
Think about your veal chop again.
So that's going to be the L. So that's going to correlate with the P. So you have cord compression, head compression. I can't remember all of the chop. It's okay. I have my notebook with me.
Yeah.
Let's see. So my veal chop, late decelerations is going to be the placental insufficiency on the veal chop.
Mm-hmm.
So with too much oxytocin, the perfusion's not occurring correctly because there's too much contraction. Like there's not enough lag time between contractions.
Mm-hmm.
Okay.
Yeah.
That makes sense.
Okay. So if we're having too many contractions, we're not oxygenating our baby as well. Because every time the uterus contracts, we have a decrease in blood flow to the placenta.
Yeah.
So if they're too close together, we're not getting enough perfusion to baby.
Okay. Yeah, I experienced that with my first one without oxytocin, or my second child without oxytocin.
That can happen too.
Mm-hmm.
Absolutely. But if we're causing it, we need to turn it off.
Turn it off. And there's no, that's just like a standing order. You turn it off, notify the provider, and then go from there.
Yeah. And so truly what we normally do, and the hospital will have its own policy. But what we do is we turn it off and we wait for our tracing to be reactive and reassuring for at least 30 minutes. So moderate variability, accelerations, no decelerations. Then after 30 minutes, if we have reactive reassuring tracing, then we can turn it back on. But we're going to start back down at the low amount because we start it, depending on the order, we start at either 1 or 2 millunits per minute, and then we can turn it up by 1 or 2 millunits per minute every 30 minutes. So if she was on 8 and I shut it off, then I'll probably start back at 2. I'll probably start back at 2. Unless the doc says it's only been 30 minutes, you can turn it on at half. But most of the time, we're going to start back at the bottom and work our way up again.
Yeah.
Yeah.
Gotcha.
And then I know at 8, we were having tachysystole with late decels. So I'm going to be really cautious about turning it up that high.
To bump it up, to get it back to that level, you kind of take slower baby steps.
Yeah, I might hang out at 6. If the baby looks good at 6, I might hang out at 6. But then if we're not, it's kind of just an ongoing process. You assess, so then I check her cervix. If she's not making cervical change, then I might need to increase my power. So then I might turn it off.
Yeah, and that was one of those things, like I was, because they say don't use your own experience to study for the class, and me having 3 kids and 3 completely different births, I try and remember that, but like they gave me at 30, I was 38 weeks, I was having the late decelerations and I wasn't progressing. So they gave me the option. They could give me something to try and help me progress, or they could stop the labor and see what happens tomorrow.
Mm.
And, they explained the risk of C-section and whatnot. So we did tributaline, stopped the contractions, and then I went into labor naturally the next day. And I mean, it took maybe 4 hours and she was out.
That's perfect. And that probably
had-
saved you having a cesarean.
Yeah, I had intense contractions with her.
Mhm.
I mean, and there was no excess drugs until after my epidural. They didn't start the Pitocin until after the epidural.
Yeah.
So it was interesting to see how strong they got, because they were literally on top of each other.
And that's when we talked in class about precipitous labor.
Mm-hmm.
That's what we're talking about and so you can have uterine tachysystole without us doing anything. Your body can do it on its own.
Yeah.
And then our babies sometimes get mad about that too, because then again, we're not perfusing the placenta every time that uterus is contracting. And sometimes we're giving tributaline then too, to kind of space that out and give that baby a break.
Yeah, I was having no cervical progression whatsoever, but the contractions were progressing to the point where I was having, I think I had 4 or 5 in a 10-minute period.
Mm-hmm.
I mean, they were literally on top of each other and nothing was changing.
And that's horrible for you. So I'm glad you got an epidural.
Yeah, no, that was painful.
Epidurals are amazing.
Yes.
What do you think for this when you selected early decelerations? What is our cause for early decelerations?
So early decelerations is head compression, and I was going with too much contraction too often, compressing the head, as opposed to the perfusion of the placenta. I didn't think that far.
Okay. Well, and head compression isn't dangerous. Early decelerations are totally, we tolerate those. Babies babies tolerate it. Doesn't interfere with their oxygenation. They just getting squeezed.
And you would see that as they're changing station and descending down.
Yeah.
So that would be something to be expected.
Yeah, very normal. Good.
Okay. I can put that together now.
What is the purpose of rhodimmunoglobulin to protect the baby, the next baby? It protects the next baby from what?
Your question screen hasn't changed.
Oh, that's my signal then. The choices are red is Rh positive blood, blue is rubella, yellow is physiological jaundice, and green is being affected by Rh incompatibility. Did the screen change yet?
Nope.
Oh. That's really strange. Am I paused too?
No, I can hear you fine. I don't have the video popped up. Let me open it up. Oh no, I can't do anything on my Zoom screen.
So if I change to my other connection, it's going to pause for a second. Let's try it.
Okay.
Can you hear me? Can you hear me?
Yeah, I hear you just fine.
Okay. Now I'm going to try to make, does the screen look like the answer was answered?
Mine does on my Kahoot, but on the Zoom screen where you're sharing, it's still on the oxytocin infusion question. So I'm wondering if it I mean, I don't know why it would only affect one of my windows if it was my internet.
That's weird. Well, I switched my signal. Connection issues. Do not refresh this page or click back, as this will end the Kahoot. Will automatically try to reconnect to the server.
Yeah, it kicked me out of the Kahoot too. Maybe it's a Kahoot server thing. Oh, my Kahoot's back on.
What about on your
My-
screen?
My Zoom is not. My Kahoot screen is fine, but my Zoom is not.
Okay. I'll tell you what, there's only two
Should I
questions.
try and log back into Zoom?
Nah, we'll
Okay.
just do the last two questions of the game. It might be a Kahoot issue and not me. I don't know.
Yeah, because I hear you just fine. There's no delay or anything that I can tell.
Yeah. Let's see what happens. Next question. The nurse assesses the fetal heart rate to be 180 beats per minute. What might be the most likely cause of the fetal tachycardia? Red is maternal infection. Blue is gestational hypertension. Yellow is gestational diabetes. And green is consumption of recent high sugar snack.
I don't think sugar causes tachycardia.
No. So maternal infection was the correct answer. If the mom's infected, oftentimes the baby's heart rate also goes up.
Okay.
What infection are we thinking about?
The choreo. Yeah, the one I
Yeah,
can't.
chorioamnionitis. So
Chorioamnionitis.
yeah, and so in class today, they were calling it the C word. And I said, we abbreviate it and we call it choreo. As long as you understand that if you see, I try to say like and not abbreviate a lot when I'm talking to you guys, but sometimes I say choreo instead of chorioamnionitis, or I say PPROM instead of when I was trying to say, okay, preterm premature rupture of membranes.
Mhm.
In practice, I just say PPROM. So I stumble myself
Yeah.
saying the P's and stuff like that. So, but at least for you guys, I try to say it correctly. But if you know choreo is chorioamnionitis, if you see it, then that's fine.
Okay.
Which is the priority nursing action for the client with an ectopic pregnancy? Assess for proteinuria is red. Check for electrolyte values is blue. Monitor for signs of infection is yellow, and monitor for the pulse and blood pressure is green.
And what was the question?
What's the nursing action for ectopic?
Be yellow infection.
We're gonna monitor blood pressure and pulse.
That's the green one, huh? Okay.
Because we're worried about if
Rupture and then
ruptures.
hemorrhage.
Exactly.
Okay. So infection wouldn't be an issue until way later.
Exactly. So priority is the bleeding.
Okay. That makes sense. I was going to ask you something, I think, about the second to last question, and then I forgot what it was.
Okay.